Good morning, everyone. Can you hear me? Okay, good. All right, and as Bridget said, I am Ariel Adams. I am the IRF QRP coordinator at CMS. I just have a quick update before I start my presentation about IKEYS, and I'm just going to read it to you really quickly. We would like to remind IRF providers to register for access to the Internet Quality Improvement and Evaluation System, or IKEYS. As a reminder, CMS Net and VPN will no longer be required, but all users must create an account and establish credentials in order to access IKEYS. Please designate at least 2 IRF provider security officers per facility that would be responsible for approving users. Messages and reminders will continue to be sent to IRFs, but we encourage facilities to begin this process early and not wait until the last minute when you're ready to submit your assessments October 1 of this year. If you are an IRF subunit, you must use your facility's CCN when requesting user roles. I will refer you to the QTSO Help Desk, QTSO, QTSO Help Desk, and that email is help@qtso.com. If you would like to call the help desk, the phone number is 800-339-9313. Okay, everyone, I'm going to do the overview of the IRF QRP and changes to the IRF-PAI version 3.0. So this first slide is just acronyms that are going to be within this presentation. You should have a comprehensive list of acronyms in your presenter's folder. So this is just another page. So you can refer to that if you need additional assistance with the acronyms. So our objectives for this presentation will be to describe the Inpatient Rehabilitation Facility Quality Reporting Program, summarize the changes to the Inpatient Rehabilitation Facility Patient Assessment Instrument, version 3.0, which will be effective October 1 of this year, and discuss changes to the IRF-PAI manual that coincide with the IRF-PAI version 3.0. So what is the IRF QRP? The IRF QRP establishes IRF quality reporting requirements as mandated by Section 3004B of the Patient Protection and Affordable Care Act of 2010. Section 3004B of the ACA amends Section 1886J7 of the Social Security Act, requiring the Secretary to establish quality reporting requirements for IRFs. Each year by October 1, CMS publishes the quality measures that IRF providers will be required to report. So what if your quality data is not reported? So IRFs that do not submit quality data are subject to a 2 percentage point reduction in your annual increase factor. Additionally, Improving Medicare Post-Acute Care Transformation Act of 2014 requires the submission of standardized data by long-term care hospitals, skilled nursing facilities, and home health agencies, along with IRFs. We strongly encourage submitting all of your quality data before the established deadline, so if there's any issues, we can look into those submission issues. So who can see your data? So CMS must report this data to the public, but we do give the opportunity for providers to review this data prior to it being published. And this data is published via our IRF Compare website. The IRF Compare website began reporting quality data within the late 2016. So meaningful measures. So our meaningful measures framework is a framework that guides how we determine what measures we're going to require for reporting. It really guides measurement and improvement within CMS. We like to focus on core issues vital to providing high-quality care and improving patient outcomes. Our meaningful measure areas serve as a connection between our CMS goals, our measures, and our initiatives. We like to demonstrate high-quality care for our beneficiaries, and some of the examples of our meaningful measure areas include our hospital-acquired infection interventions, as well as our prevention and treatment of opioids and substance abuse disorders. So quality data for IRF QRP is collected via 3 ways. We collect it via the IRF-PAI assessment, our CDC NHSN measures, also our Medicare fee-for-service claims. So here we have our IRF-PAI measures. We have 8 measures. We have the residents experiencing 1 or more falls with major injury. We have the long-term care hospital patient with admission discharge functional assessment and care plan. Also, we have our functional assessment measures, which is our self-care for medical rehab patients, our changes in mobility score, also our discharge self-care score, and our mobility score of medical rehab patients. The last 2 are the drug regimen reviews, which are conducted for follow-up when you identified issues, and changes in skin integrity, post-acute care, pressure ulcer, and pressure injury. Our CDC measures include our catheter-associated urinary tract infection measures, our healthcare flu measures, and our C. diff measure. Sorry about that. Okay, and then our claims-based measures, as you see, our Medicare spending per beneficiary, our discharge to community, potentially preventable 30-day readmission, and potentially preventable within-stay readmission. And these measures are collected when we submit claims, so they do not require additional submission of data by you. So our discharge to community measure update, we're going to give you that. So CMS has refined the method by which providers are assigned to performance categories to align with potentially preventable readmission measures in the IRF QRP and the hospital-wide readmission measure in the inpatient QRP. So we revised this methodology and it resulted in greater variation in performance categories. So you will see that this refinement will be reflected fall of 2009 during the quarterly refresh of the IRF Compare website, and you will see it in the June 2019 IRF Provider Review reports. Also, update for the publication of potentially preventable readmission measures. So CMS postponed publishing this measure until we allowed for more testing. We have now completed that testing and will publish this measure fall of this year. So CMS has refined the method for assigning providers to performance categories which indicate their level of performance compared to the national rate. This refinement will be reflected September of this year, the IRF Compare quarterly refresh, and June 2019 in the provider preview reports. Okay, so we're going to briefly go over the measures from the IRF QRP that have been removed. So we removing the percent residents with pressure injuries or ulcers that worsen. This measure has actually been replaced with changes in the skin integrity measure, and you will continue to see this data until the new measure comes in fall of 2020. Also, the removal of the percent of residents who are assessed and given the seasonal flu vaccine. The last refresh for that measure will be December of 2019. The removal of the MRSA measure, data collection ended October 1 of 2018, and the last refresh will be fall of 2019. And the last one, removal of all unplanned readmissions for 30 days measure. That was also removed. So our training is really a focus on collecting accurate data. This data is used to calculate the assessment-based quality measures to calculate process or outcome, identify inclusion and exclusion criteria, as well as apply risk adjustment to outcome measures. So therefore, it's just very important to collect accurate data. So we're going to move on, and we're going to discuss some of the changes that occurred in our IRF-PAI version 3.0. So again, this version will be available October 1 of this year, and we have provided several links to the IRF-PAI and supporting documents. And everyone should be able to access those. Those are on our CMS website. So some of the changes that occurred from version 2.0 to 3.0, we deleted functional modifiers, deleted the FEM instrument, and deleted section 0A through 00250C. So this is just a slide demonstrating the removal of that. We did remove that due to our prospective payment system revisions of the FEM. So we removed like I said, the FEM and the functional modifiers associated with that. And this is just a slide reiterating that. And you see for section O, since we removed the patient influenza quality measure, that this part of the section O was also removed. All right, so changes that we made to the IRF-PAI manual. So we did take your feedback into consideration when giving that to us. So we did try to make it more user-friendly and up-to-date. We also changed the name to the IRF-PAI manual so that it's just more clear what the purpose of the manual is. Overall, the format has been changed. We did combine the IRF QRP and the PPS sections. We do have 4 chapters that specifically focus on IRF-PAI coding guidance and 5 appendices, which actually serve as great resources for providers. We also added the administrative information and quality indicators section. We incorporated into chapter 2, which is the item-by-item IRF-PAI coding instructions. And we also changed the title of sections to the title of chapters, so hopefully that's a little more user-friendly. And I won't read this to you. I'll just let you guys read this, but this is available for your information. And the appendices, these are the title of the appendices that we have. Okay. So some of the guidance changes. Of course, we removed the information related to the FEM items and associated functional modifiers. We removed information for the flu vaccination. We also changed the definition of major surgery and removed the general anesthesia as criteria for major surgery. We did this to make sure that we could align with the other PAC settings. There was also an update for the clarification of terminology, removal of the FEM items, and addition of new terminology. Okay, all right. So if you have any questions for me, please submit those questions via Slido. And I'm going to turn this over to my colleagues. Thank you for your time, and thank you for being here. We greatly, greatly appreciate it.